Hello. In this session, we will review the Therapeutic Drug Monitoring Service and the Clinical Pharmacokinetics Service, and we will address some of the basic pharmacokinetic principles that we may refer to sometimes during the course. We will address how we design drug regimen and what do we monitor, and the rationale to have Therapeutic Drug Monitoring Service or justification, and the element of a consultation. That's pharmacokinetic consultation. Then we're going to go into the application and some of the review of selected principles, such as how to initiate dosage based on the population parameters, and if you have a blood level and you want to increase or decrease this level, then what kind of dosage modification you will need to do, and that is adjusting dosage based on measured level. First of all, once a decision is made to treat a patient, and this is a group decision, and sometimes it happens by the physician on his or her own without the pharmacist being available, then drug and dosage selections are made based on the diagnosis and the goal of therapy. The next step in the process is to order a dose and monitoring parameter like drug levels or kidney function or liver function tests. The dosage calculation at this stage is based on published pharmacokinetic parameters, i.e. the population values. And once you receive the level from the lab, then the interpretation of this process takes place. And this is a very important step because the levels are representation of the patient talking to you, telling you how they clear the drug, how they handle it. And correlating this level with patient response is something that we are required to do. So a decision can be made whether we need to change the dose to achieve a different level or not. So interpretation of the level and patient response constitute a significant component of the therapeutic drug monitoring consultation, and later on the dose that is needed. At this stage, we try to estimate the patient's specific pharmacokinetic parameters and use it to calculate any dosage changes. The rationale of having Therapeutic Drug Monitoring Service is really well researched, because we have documented that having a service like this can enhance patient outcome, provide cost saving, and minimize liability or adverse drug events. And we have here supportive or supporting literature. I have a link or links to 5 studies that show these benefits. You are encouraged to look at least at the abstracts and read it, because this is what contributed to the significance or realization of the significance of clinical pharmacists or pharmacokineticists. The element of the therapeutic drug consultation in general should include what do you think the patient pharmacokinetic parameters are like, and what's the goal of therapy with regard to blood level or response, and what dosage would you recommend, and what monitoring parameters you like to see. Within the monitoring parameters, of course, the blood level is very significant, and the time to draw it is very important to include. Who is involved in therapeutic drug monitoring consultation service? We really have almost everyone. Pharmacists play a major role, but physicians, nurses, lab technicians, pathologists are involved as well. This slide was designed to just give you a couple of minutes to try to answer or complete the spaces here. The answer from the literature to just the justification of therapeutic drug monitoring service, as we indicated before, is better response and faster response, or reduced time to achieve the goal of therapy, i.e. specific blood level. Also, less toxicity or adverse drug events, decreased length of hospital stay, and cost saving. The element of the consultation include estimated pharmacokinetic parameters, desired goal of therapy, recommended dosage, and recommended follow-up or monitoring parameters. The loading dose is estimated based on the volume of distribution and the desired concentration. You just multiply both parameters together. The maintenance dose is determined by the clearance. And of course, the consideration of the bioavailability and the salt fraction must be in place. Now we're talking about the application and review of basic pharmacokinetic principle. The first step is how we initiate dosage. This is done based on the population parameters. So we assume population pharmacokinetic parameters that best fit the patient, and we calculate the dose based on this parameter. We order drug level, then we evaluate that level as well as patient response. If we have a level that we do not desire, then we need to adjust the dose, and this process must be proceeded by estimating the actual patient, not the population parameter that we have used before. We use the reported lab value and the dose to calculate the patient exact parameter, whether it is clearance, volume of distribution, half-life, KE, elimination rate constant, or any other parameters, and we then use this parameter to calculate the new dose that we would like to use in order to achieve our goal of therapy or our goal of a specific blood level. I would like you to take a minute or two to just try to answer these questions here. So you may pause the video and do that. If you have two levels and the time between these two levels, assuming no doses is given here or are given here, then you can use these two levels and the time difference to estimate the elimination rate constant KE. And from there you can of course calculate the half-life. And if you use population volume of distribution, then you can calculate patient clearance. Therapeutic window is the range where the probability of response is very high and probability of toxicity is very low. The volume of distribution is a hypothetical volume that we use to estimate the amount of drug in the body or the loading dose. The units are volume unit, like liters or liter per kilogram. The clearance is the amount of this volume of distribution that is cleared from the drug per unit time in first order kinetics, or the percentage eliminated in saturable kinetic drugs. It's used to estimate the maintenance dose, and the units are volume per time. The loading dose is the volume time desired concentration, and the maintenance dose is the clearance time desired steady state concentration. And remember that the population value of clearance and volume of distribution are published for each drug, and are only used to calculate initial dosage. But once you have a level, a drug concentration, then this must be used to calculate patient value and use it, not instead of the population value. Okay? A single blood drug concentration is used to calculate the amount of drug in the body by multiplying this concentration by the volume of distribution. A steady state plasma concentration that is obtained after the patient receiving the same dosage for about 5, 7 or 10 half-life can be used to estimate clearance by dividing the dose over that concentration. The dose may need to be, if it is not an IV dose, may need to be multiplied by the bioavailability, or the salt if it is not a pure drug. If you have a two drug concentration, a drug C1 declined to C2, and the time difference, then you can use this 3 parameter to estimate elimination rate constant. It is ln C1 over C2 divided by the time difference, and from there you can calculate half-life and maybe clearance. Okay, thank you very much.